Good afternoon, everyone, and welcome to the first seminar this semester. We are very happy today to start the series with Dr. Faysal El Kak, our colleague. Now, Dr. El Kak is an associate professor of public health practice at the Department of Health Promotion and Community Health at FHS. At AUBMC, he's an associate professor of clinical OBGYN. He is the director of the Women Integrated Sexual Health WISH program, and he is also the director of strategic business development. Outside AUB, Dr. Kak is currently the president of the World Association of Sexual Health. Dr. Kak has authored many research papers, book chapters, and media articles covering women's reproductive sexual health, displaced populations, and survivors of violence. Please join me to welcome Dr. Kak to our talk today.
Thank you very much, Dr. Kanj. And thank you for being here. My task for today is to highlight on what I think is a marginalized topic and to convince you in my both public health and medical health that menopause and menopausal transition is and can be a public health initiative or movement. I'll be talking about the global population and the type of senescence that occurs in the transition, redefining the menopause transition approach and menopause as a public health issue. I have nothing to disclose financially. I sit on a couple of boards that has to do with menopause in the region and globally, but I'm not paid for this, unfortunately. Well, we're going to start with a paradox and how this menopause paradox positions itself within public health. And I'll start with the question is why menopause, which is transition experienced by half of the population, still whispered, neglected, and treated as decline. And I think this is a time to change that narrative in an aging population where the whole world is aging and also womanhood is aging. And you can see between 2020 and 2030, if you look at the pink, you can see the increasing in millions of the population of females at a time when we believe the health systems and the work environment is not ready for that. This is the growing population of women in what we call menopause transition. By 2030, we're going to have 1.65 billion women transitioning menopause. And by 2050, you're going to have 2.2 billion women transitioning menopause. And we believe less than 10% will be able to receive the attention, whether in the health system or at work, that they deserve. Especially that you see here, 40% of life will be spent in the menopause. So 40% of those people will be spending their life in that menopause with an average age of 51.4 globally. In Lebanon, it's 49.2. We published a paper with Marwan Khawaja and Saliba Matild in the Saudi Journal of Saudi Medical Journal. And this paradox continues because if you look at the public health strategies, menopause is excluded from the public health strategies in the sense there is no menopause framework. We are working on this just last year and this year. We have a meeting in Geneva next week that menopause is on the list. So they're starting to move it, but otherwise there is no framework. Gaps in workforce and policy continues, and the biomedical models are still dominated by silence, by gaslighting and marginalization. With the coming physicians, this is from Mayo, 7% only of the coming OBGYN feel they are only skilled to approach menopause. The others not. And there is no public health curriculum on that topic. At the same time, this is from different women in different places. I felt dismissed, gaslighted. Why no one prepared me for this? like they prepare women for menses, for fertility, for pregnancy. And 75% of those women who seek help feel the provider is not equipped and ready, with a lot of cultural stigma and lack of the open dialogue. This even takes more importance if you know that we're the only species, or we are the only, the humans are the only ones with a menopause. There is no menopause among other primates. Okay? And that means you're going to face more of this longevity issues later on. There are only two entities known so far, or only one entity, which is the killer whales. Killer whales and human females are the only ones that have a menopause. And lately, there are some type of chimps that they're studying. And why is that? Because whenever there is ovarian death, there is also somatic death. In all the other primates and species, women die when they stop ovulating. It's only with the humans and the killer whales that there is a somatic aging beyond ovarian senescence or ovarian cessation. And that is interesting. As you can see here, like we're only one extended, and all the others, there is an overlap between ovarian aging and death. And if you look at the phylogenetic tree, you can see there are some aspects to that. There is the aspect of the anomaly of longevity that happened, that humans, they are living longer over time. There is also the behavior that has to do with mating, especially men mating younger women. And there is the grandmother theory, which is the most popular theory, but none of these is really conclusive in that sense. As I said, there is now more and more research on special type of the chimpanzees who are living 20 years, and the other one that appears in the famous series at Netflix, The Chimp Empire, they live 30 years after their last pregnancy. They're now 6-7 years. It's exactly the same chimp, Garbo, that played in the Netflix, is now 67. The pregnancy was at the age of 38. One similarity between this and the humans is that this type of chimps, they lived in a place in the jungle where they were not threatened by other animal offenders or species. So if you're going to look at all of this, what do they have in common? One is the strong grandmother theory, okay? The knowledge transfer, the matrilineal social structures, and all of this suggests social complexity and not phylogeny. It's not like an evolution, with the chimps, with the bonobos, and then we went up there. No, it's more of a social structure where there is a role for senior people, and there is a knowledge transfer, and that explains the menopause. So by definition, menopause is the cessation of menstruation for 12 months. And people wonder why this is happening at the age of 49 or 48 or 51 or 55, because recently it has been shown that this is genetically determined. There are around 290 genetic variants that determine the age of menopause. And that's why you have 2 to 4% having a pre-menopause, okay, around the 45. And then you have 8 to 10% at perimenopause, and the rest are in the menopause. So they still have some proportion that will have an earlier menopause, and that has a lot of implication for their longevity, because the new genetic theory explains that those who menopause earlier are going to have more health problems than those that menopause late, because those with the later menopause, they have a better genetic repair, and that's why their ovaries age at a later stage. So that's basically what now genetics is trying to explain, is that although you have a similar track that guards the ovarian aging and the somatic aging, but at one point there is more continuation of the soma, because if you think about it, Ovary is the only organ that the woman live without its presence. See, well, you continue your 40 years without the ovary, but you still have the heart and the brain and the lungs and the other important organs. And that's because, and it's very interesting, that's because there are extra genetic variation that takes care of the brain and the lungs and the stuff besides the ovary. The other thing is ovary cannot afford to make mistakes. And that's why ovarian aging is not about you're ovulating more than the usual. It's about atresia. And atresia is a pre-programmed genetic phenomenon. So you have this amount of years to ovulate. And as you grow older, there are more genetic mutation. So it comes to a place where there is more mutation than there is healthy outcome, then the ovary stops. It's like a factory making fault cars. The factory will stop. It doesn't repair itself like a lung or a brain. You can live with this or that. So there is this kind of, you cannot afford more mutations, so you need to stop. And that's why now there is more research upcoming on how to prolong ovarian aging by delaying the process of mutation or mitigating or lowering the mutation that can happen. I don't want to spend, this is not the whole talk, but I just want to give this introduction just to show the importance of positioning menopause not only as a reproductive cessation because of the ovary, but more because of its impact on longevity and the health outcome later on, and what we can do as a public health professionals. Yes? They're born with somewhere between 1 million and 2 million, and then you start losing it. By the time you have your first menses, they drop all the way down to like 400. And then you keep losing it. So that's why it's atretic. And it's atresia. When people ask, if I ovulate more, if I take birth control pill, this will delay my menses? No. It's a pre-programmed atresia. That's it. You stop. Because you cannot afford more and more mutation. Because if you look at the age of 20, you're pregnant, your risk of trisomy 21 is, let's say, 1 in 417. But if you are at the age of 45, the trisomy risk will be like 1 in 40 or 1 in 30. It's a lot. Yes, 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 you're right. And think of menopause as the power plant and the light bulb. It doesn't apply to Lebanon, of course. But Lebanon هي menopause من الشركة. So this is the whole body, and that's the ovary. Okay, so there is one organ that is not functioning, but the rest of the body should continue to function. And this is important when you want to destigmatize the talk around menopause, because menopause, it means my body is this, my body is that. It's not true, because it's not necessary, because that line of guarding the soma is continuing. Why? Again, we don't have a full explanation, because you have different theories and they're all strong enough but not very conclusive. As I said, the grandmother hypothesis is adaptive menopause theory. There is more benefit to nature and to the society in the older woman investing in raising grandkids than herself getting kids who will have a higher risk of mutation, plus the transfer of knowledge, plus the social support. There is also the germline protection theory, which is about the apoptosis and the ovarian cessation. And there is the programmed ovarian aging, which is, again, it's more beneficial for the ovary to stop working at a certain age because of increased genetic mutation. And there is mating of younger female, and there is also the longevity anomaly in the language of the population experts. So on this first part, I want to emphasize that ovarian failure is not somatic aging. And the programming is gaining more and more popularity in the sense there is more to gain in women stopping getting pregnant at a later age and investing in grandchildren for the society. And also it's about the genetic repair. If we are able to come up in the coming 5 or 10 years in a genetic repair mechanism, that will prolong over an aging, and you will see women getting pregnant at the age of 55, probably, and 65. Because if you have a woman who froze her eggs at the age of 20 and she wants to get pregnant at the age of 50 and 55, she can, or at 60. The soma is ready for that if she has no serious medical condition. So the thing with the genetic programming is how much you can push or delay the mutation and the aging and having a better repair of the DNA. And this is part of a Lancet series. This is a painter who showed in an exhibition in Australia 500 bodies of menopausal women in a very artistic way, just to show that these bodies and those women are as competent, as integral, as whatever you want to call it, as any other woman across. And in this amazing series in the Lancet, there was a call by a group of experts, public health, medical experts, on time to change the narrative around this. It's time to take the stigma that the older woman already is facing. It's time to reassess identities and embrace the next phase in the lives of those women, okay, and the freedom from menstruation and menstrual pain. So to rewrite the narrative. At the same time, menopause doesn't herald the start of a period of decay and decline, but it is a developmental life stage that can be negotiated with success and with a chance to access resources and better work environment. And following this call by Lancet 2022, from the art scene, from the medical, from the public health, can or is menopause a public health issue? If you look at it as a universal phenomenon, and it is a universal phenomenon, a long duration health transition with preventable morbidity and inequitable outcomes, ignored by health system, it is a public health problem. Sheikh Tamar, by definition, that's the criteria. Tamar can lay في criteria لل public health. So there is a population level exposure. We're talking about 1.2 to 1.3 billion women in 4 years, and we're talking about 2.2 billion women in 2030. Predictable health transition, I can guarantee you this as a gynecologist on my other hat. Socially patterned impact with a lot of injustice, with a lot of inequity, and system failures that were not ready, whether in the health system itself or in the work system itself. And that's why I'm going to call for the 6 and the 3 buzzword. The 6 are the 6 steps that you need to change this narrative of the menopause. Access to information, shared decision making, creating a menopause-friendly work environment that we're working with as a Faculty of Health Sciences, WISH program, and ASFARI with the AUB administration. Access to tools supporting decision-making, challenging stigma and gender-based ageism, and also to quality, inclusive clinical services. This is the 6 steps. And the 3 realities are, this is AI-generated slide, by the way. Health is the first reality, chronic, mental, and physical. Quality of life in terms of daily life and workplace, and healthcare and public health support are the 3rd reality. This is a very interesting paper from the UK about the role of menopause on future health and longevity. And you can see in the A pie is the menopausal symptom distribution. You can see the bulk of this are the most bothering vasomotor symptoms of night sweats and hot flushes and flashes. And there is also weight gain, and there is also psychological and cognitive issues. And if you look at the medical outcome, again, you can see many of the chronic conditions, whether mental health or physical health conditions. They're not caused by menopause, but they happen partly because of the menopause, and at the same time, within 10 to 15 years from the menopause, most of these conditions are happening anyway on the life course. And this was captured by the British Menopause Society at the work level, at the social lives that can take a back seat. Many women, they isolate themselves socially, sexual life of the menu in a big percentage of people, and also the impact on the partner, either feeling helpless or not able to communicate with the usual condition with his or her partner, depends. So this is really a multi-layered issue that you can do, you can suffer from. And you see in details, the menopause transition is affecting every physical and psychological side of our life or the life of the woman. In addition to the most talked about now is the brain fog, where women report that in the transition, 60% will experience a change, not only on cognition also, but in another aspect, which is considered a basic task of female, which is communication and fluency of expression. This is more in female than in male. That also is lost in this menopause transition. And they don't wait for you. Like, they don't like, now you're going to feel this, tomorrow you're going to feel that. If you see these colored curves, you can see that the physical symptoms and the behavioral symptoms and the psychological symptoms, they overlap with different intensity, and also they feed into each other, okay? So you have the physiological health and symptoms, and then you have the subjective symptoms. Yes, there is vasomotor, but I have, for example, we see in the clinic, people coming with different perception, with different intensities. They cannot sleep, they cannot function, they cannot focus, and also the psychological in relation to mental health, sexual function, and also to cognition. So they start working all the way together. If you look specifically at the vasomotor symptoms, these are the most bothersome and the most really, so to speak, disabling symptom that can stay with the menopausal woman up to 7, sometimes to 10 years. The average is 7, but they can go all the way to around 15 years. And they come at a time when many of the menopausal women are in a higher positions at work or in other places, but specifically at work, these are either CEOs or to become CEOs or to become senior academicians or leadership or whatever. Currently, according to Bloomberg, we have around 660 million women in the world, 45 to 59, almost 50% are employed. And these are some of the studies I've collected. And you look at this economic, look at the economic impact in terms of the money lost, in terms of the days of work lost, and look at the feelings of fatigue, anxiety. 900,000 UK women left jobs just for menopause and because of menopause. So there is a financial burden, and there is a psychological burden, and there is an economic burden across all of these studies. In specific, in this study, you can see the impact of work because of the menopausal symptoms, where up to almost, if you add this up, between 50 and like 20 to 50%, they feel these symptoms all the time or more than 50% of the time. And that's a lot, especially when no one is caring about this and nobody is trying to help in that regard. And these are not easy ones that not only affect your life at work, but also your life everywhere. And in specific, it impacts disruption from work, sick leaves, lack of promotion, shifting to part-time, so on, and stopping night shifts, so on and so forth. Again, there is a lot of money lost in this regard, and there is a lot of people who are changing work, losing work, making mistakes, losing interest in the job, okay? And at the same time, not able to report any of these symptoms. The third aspect, besides the impact on work, is the impact of the stigma and how this varies among different communities. And again, you can look at menopause from an anthropological perspective. This is reported differently in different communities. You can see in most of the paper in the West, it's about hot flashes. If you look at the African-American Hispanics in the US, it's more about vaginal dryness. If you look in the Middle East papers, we've done this with, as I said, with Marwan and Matilda, and we have 2 other papers from Saudi and UAE, and they're talking, most of these papers, about musculoskeletal pains. And there is the DAME study led by Carla Obermeyer in 4 different cities, including Lebanon, Barcelona, Rabat. Again, most common ones in this part of the world is musculoskeletal versus the others. So again, the way people report can be different depending on the context. Shoulder pain in Japan, low vision in India. So 1 in 5 didn't know who to ask for help. That's at work. And although around 1/3 complain, only 11% were able to talk about it because they were deterred by stigma. The American College of OBGYN raised this issue in terms of, I was talking with Dr. Zrei, the misinformation, disinformation, that public health can do much about it, but it's really flooding the social media with a lot of things about menopause and menopause transition that's not true. And only femtech alone, as an industry, is making around $16 billion out of lying or telling female stuff with no evidence. There are 3 companies that have been closed because they are claiming stuff without any evidence, telling women about it. So this is something that will need a lot of our attention. They sell combination of substances, they sell exercises, they sell certain practices to do. To make sure that others adapt. And they sell also stories like, we can prolong your menopause, you can keep you menstruating, and that will do much better for you. It doesn't, because you're making them menstruate outside the ovary by giving them external hormones. So there is no evidence based in most of these things. And this is happening where 90% of people, they hold gender biases. We see this. We see this in the clinic. Many of the cases I see in the clinic are referred by colleagues in the department at the ABMC who have been gaslighted and marginalized for the symptoms. So مش إنه عم نحكي underprivileged, marginalized. It's happening here among us. Menopausal woman. Yeah, in this place. And 50% hold ageist attitudes still, according to reports from UN and WHO. So all this is just to convince you more that menopause is a public health matter. And why? There is, Lillian, there is epidemiology and the longevity paradox. There is health policy. We don't have any clinical PH guidelines. We write a short policy, a brief policy, I would say, with Asfari. But I mean, we're doing one in the region, but there is more to be done in terms of public health guidelines, insurance coverage for menopause care, mental health issue, and of course, the whole issue around injustice and inequities in terms of global health. And I believe we must act earlier because, if you want to remember one thing, is that public health can intervene in that window of opportunity. Like we can position menopause not only changing narrative as something positive, which is something in each chapter, which is, but also it's a window because most of the issues that happen not only in the physical and the psychological, but also in the social and the work and the cultural is around this time. Just to give you an idea, for example, 95 to 96% of pregnant women, they are followed by physicians and they go to deliver in hospitals because fertility is positioned in such a high place in our community and our society. And all the family, they come with a pregnant woman. When you finish fertility, you finish pregnancy and you become perimenopausal and or pre or peri, no one even pushes you to go. بيطلعوا بيلبوردز على الماموغرافي الا ساعدها تروح خبرها تروح تعمل ماموغرافي يعني انه push her to go. You know what I mean? Because so if you position menopause in the sense of window for, especially there is a whole lifespan after menopause. You're talking 40 years, you're talking 35 years, and usually these issues, they don't happen at the age of 20, and they happen at the age of 45, 50, not because of menopause, but because this is the life course of ovarian and somatic development. It happens, ovaries stop, but the soma, we continue to live for 40 years. So that is the nuance, and the framework would be that public health, menopause, they intersect with the health system, with the workplace, community, everything around research, measurement and data, and equity dimensions. And all of these issues are at the core of public health. It has relevance to Lebanon. It has relevance to the region, because in the region, the rough estimates is around 35 to 40 million women who are in the menopause transition in the Arab world. 40 million. With a region with a high NCDs burden. For the health system, for example, public health can create menopause-aware primary care protocols, preventive bundles that are important, preventive bundles because the whole risk of fracture, heart disease. I mean, even physicians, they don't know that the #1 killer is the heart disease in women. They attribute this to men. They think no, men only have this heart conditions. It's even more in women with symptomatic menopause. Night sweats alone will increase the risk of heart disease in women by 3 to 4 times. So when you tell the woman to tough it up, to be gaslight, to طولي بالك وشدي حالك على night sweats, you're telling her, I'm increasing your risk of heart disease, of heart attack. And that's proven. There is a strong correlation between the vasomotor symptoms, especially the night sweats, and cardiovascular risk. And that's why this risk is much higher in the 5 to 7 years following menopause as compared to the rest. But still, if you look at the overall burden of death in women, it's heart disease. It's not breast cancer. It's heart disease. And this bundle can include also mental health, vaccination. Vaccination now, there is a new data released 2 weeks ago that the Pneumovax and the shingles, تحديدا shingles vaccine, will reduce dementia by 30%, the risk of dementia. 30%. Because it has to do with prevention of accumulation of protein myeloids in the brain. Symptom screening in midlife visits and electronic health records and menopause metrics. All these can fall under the public health jurisdiction within the health system. At the population level, you can look at all of these risks and work on it. This is community health. CVDs, cardiovascular osteoporosis, metabolic syndrome, the menobelly, the weight gain around the waist, cognitive and mental health shifts, sexual health, and underdiagnosis and treatment. In this paper by Lobo, published 2022 in The Lancet, they also propose that menopause can be a view and a way towards prevention and the preventive measures for women. simply, as I said, because there is a cluster of these conditions happening around that time, especially some of them like obesity, hypertension, they have 10 to 15 years after menopause and breast cancer risk. So this is directly relevant to preventive public health framework that rests on prevention, on screening, and advocating for hormone therapy, which is also very important. In a recent data, contrary to what people think, انه ما تاخدي هرمون ما بيسوى, those who have started in the perimenopause in hormone therapy have a better and longer longevity as compared to those that didn't take hormone therapy. And still, the femtech social media thing تقول لك ما بيسوى تاخد هرمون بيعمل لك كانسر. Estrogen protects from breast cancer. It's all over the place. It's not me. It's on the papers. Okay? In the workplace, this is an excellent paper also published 2024 on interventions in the workplace, a public health intervention that can take from flexible hours to training managers and human resources to menopause-friendly health promotion to also monitoring all the work aspects. And we are, as I said, we're doing this. يعني the dean Asfari, myself had a proposal, especially for the workplace. We're also doing a new program now that I'm leading for the health and the clinical services, and definitely to be in close collaboration with the faculty. As for the community awareness through NGOs, clinics, and media, peer support, we can do a lot in raising also the noise around menopause to be included in the services as public health. Peer support network, outreach in mobile community clinics, co-design with women's groups. This is a very interesting paper using Longwiz ممكن تعرف شو هو Longwiz framework. I read about Longwiz. It's designed by Sarah Langwe. It's especially for any study that has to do with empowering women. So whenever you want to do a research using a scale to empower women, there is this Langwe framework in combination with the proceed, collecting data at baseline 2 weeks and also at 4 months. And they have shown in this RCT that a structured self-care training program based on empowerment theory and community engagement effectively enhance the health outcome and the quality of life of postmenopausal women. And that's also something for us we can do now. We're running in this faculty, Michael is taking care of this, our GA. I'm sure you received this email on menopause perceptions and knowledge and stuff. So please, يعني أكيد we sent out 800. هلا أنت فوق 70 نحن قلنا للي تحت. So anyway, we're running this. That will be the first study within EUB to understand how people feel around this. The other aspect is data measurement and evaluation. There is a lot of indicators around how people perceive menopause, things we're doing. Also care uptake, fracture risk across life course, quality of life. Doing this across other variables like socioeconomic geography. Looking at also data from records from the workplace. And also thinking of research opportunities, workplace, community channels, social determinants of menopause health. Judy would like this. And also designing other forms of studies. I'm working on a fund, hopefully we'll get it for also menopause and menopause transition. And also policy and program recommendation. Think sectoral menu, health, work, and community, align with the SDGs. Now there is a growing interest in WHO on this issue. Evaluation and implementation science, and enable consortia and research ecosystem to serve this purpose. This is an interesting paper showing recommendations from the European medical and public health societies, again, talking the same and echoing the same language regarding policy, culture, discrimination, collaboration, and building alliances and improving the work condition. I have the last two slides talk about what can we do practically. We can work on awareness education, whether we introduce this with the UFS, Dr. Sbai, to have a module on the menopause Meta 101. We can do women health at work talks between our faculty and other faculties. Policy guideline, integrate this in the work environment. We're working on this. Environmental adjustment, even within offices and within the floors of every faculty. Flexible work arrangements, training for leaders and supervisors, where to go, what to go, counseling, whom to talk to, destigmatization, occupational health and medical support, peer and community support, evaluation and accountability, making this part of the annual AUB staff climate survey. Hopefully, the three of us are continuing to push this as a Faculty of Health Sciences, as I said, Asfari and the program. And I will finish. This is Joanne Manson from Harvard. She is the leader of the Women Health Initiative study that have changed the whole concept around menopause and hormone therapy in the early 2000s. But then she have changed this completely for hormone therapy and pushing for it. And I like this quote, menopause is a biological reality, but how women experience it is shaped by culture, policy, and care. And I think you can do a lot on this. This is a real picture, not AI generated. Later on Google. And thank you very much.
Thank you, Dr. Kak, for a very informative and eye-opener talk. Yeah, we can take questions now. Tamar?
I don't think it's a question, but kind of sharing my thoughts and with what you said, Faysal. The attention that women receive during reproductive ages with prenatal care, masalan, we have more than 95% going regularly. It's not because of the woman, it's because of the baby in our culture, unfortunately. And we have the rates of postpartum care that drop. They don't drop for the baby, they drop for the women. We also know that, women experience that loss of attention after giving birth in our culture. So that's really just continues throughout the life course of the woman. And menopause is not necessarily, different, because as you're showing very interestingly the data from different parts of the world, it's about listening to women, which is lacking. Okay, so throughout the life course the needs might change, but there's always a lack of listening to women's needs, which keeps repeating as a theme that women have to live with throughout their lives, whether that is socially or in the healthcare system or in the workplace. So it's all the same. And I think one of the things I would add on what we can do, I think we can also focus on integrating these into curriculum. I mean, I'm thinking of medical curriculum before public health curriculum. If the next generation of the medical workforce is not ready for the billions of women worldwide, so that's a big, gap we need to address. And maybe as public health professionals, we have a role to play in the medical curriculum, not only in the public health curriculum, but also I would, want us to work more on having more case studies on menopause in our programs, which is really important, and how to address misinformation related to it. So
thank you very much, Tamar.
Thank you very much, Faysal, for this comprehensive overview on menopause. Is it working? It's working. So you've mentioned the different types of signs and symptoms that women... Oh, sorry. So you've mentioned all sorts of
Thank you, Faysal. Thank you, Faysal. This has been very informative and interesting. The question that I wanted to ask is that when you talk about where this issue must be faced, you say this must be faced in the workplace, in the clinic, and in the community. Now, I don't understand to what extent family is included in the community, because the basic unit that the woman is and that is influenced by what happens to her in the menopausal period is the family, her children, her husband. And I don't know, masalan, whether in the clinic, the husband comes with the woman to understand what she's saying and what the doctor is saying. So I think the family is a basic unit also to be thinking about. Maybe in the community.
Part of the community, the same thing like schools also, it's part of the community. The assumption when you say community, as you said, doctors, you include the family and you include also the children and the school, the exposure to school. And in the course, for example, I'm teaching here, there is a chapter on menopause, although they feel very young, but I try to relate this to their mothers and grandmothers, and in a way, but at least to know what is the menopause. And they're leaving, لأنه دي مش دوري. يلا تفضل دكتور.
One thing concerned me about the presentation, it's excellent, informative, and all of that. That you took me in the first part of it, and I was seeing something that is more of a social, cultural, and then it was medicalized very quickly, and then I saw it as a problem. So it's the paradox that you're talking about. So I felt that your convincing arguments were very strong, taking us through. You have to think differently about this. It's a different narrative. And then boom, I saw that it's all about hormones and this and cardiovascular and brain and other things. So it threw me back into the medicalization of the problem. And it's a weakness, not something that we have to do. It's a vulnerability. So I don't know whether I got you wrong, but I think it's important, building on what Tamar said, there's an entry point, something where the cultural and the social should come in strong. Otherwise, the medical takes over again.
Honestly, I did not see any medical in this myself. When I was working on this, I was telling you that it took me much more time than a medical grand round because I have to bring in the public health. It wasn't medical. Medical was positioned hand in hand with the psychological and also with the cultural and also with the workplace. Because the argument is, if you have to build an intervention, if you have to make menopause a public health issue, then you have to give the public health a menu of present issues. Because women who present to the clinic, they should be validated for their symptoms. Women who are at work, they should be validated for their symptoms. Women in the family, in the community, so on and so forth. So we presented all this array of things. Of course, people feel most burdened by the physical and by the psychological symptoms. But I did not in any way intend to throw to you the issue like you have to deal with the medical. Yeah. بس كمان public health هيدا on another note يمكن انت ما قصدك هيك بس كمان public health shouldn't be frantic anytime we mention something medical because where the medicine now is going, there is so much public health. There is a lot of vacuum that public health has to fill. So all these bundles that I'm talking about, it's a public health thing. Joanne Manson is in the public health at Harvard, and many others who wrote the WHI and all the data on menopause, they're public health people, and they are social scientists. So, but دايما the physical burden is the most annoying thing that people complain of. And yeah, I know. But yeah. But we presented the whole.
We can take one more question.
But I have to go back to Dr. Merkel.
Okay, very quick, and then Nada, and then yeah. She's asking has there been any initiatives in Lebanon or the region to manage symptoms?
There have been initiative. I mean, there are initiative efforts in Lebanon. I mean, in Lebanon, we're working on the workplace, and we're working to having a comprehensive program of care with medicine and public health. We're trying to work on the policy in the workplace. In the region, we just finished writing a white paper, again, regarding positioning menopause and promoting menopause within the health systems and healthcare. As for Dr. Nada, andropause is not a medical term, yeah, I know. And you see, the reproductive life, reproductive capacities of women, they're much more sophisticated than men. And that's why you're born with ovaries and they get atretic over time, while the sperm keep on changing and stuff like this. The only problem in that sense for males is when they start having sexual dysfunction problems that are related to medical or otherwise, and if they start having low testosterone, which is the main sex hormones in that regard. For the other question, I agree, but astonishingly enough, menopause is being really brought up in WHO, at least meetings, and in the US, we did not hear of any cuts around research involving the menopause. In the WHO analysis, sub-analysis, but probably other aspects. Yeah. But at least now the CDC dropped the black box from the hormone therapy, which is
Okay.
ما بتكلف.
So there's a class now. So thank
Okay.
you very much for
Thank you.
Thank you everybody for attending, and we'll see you next week. There's another seminar next week, so please come again.